Hello and welcome to the HSJ Weekly Health Check Podcast. My name is Ben Clover. I'm one of the Bureau Chiefs at HSJ, and I'm joined by two of our correspondents here today, James Ullman, who specialises in performance, and Annabelle Collins, who specialises in workforce. And that's a particularly potent combination this week, as we've seen the release of a quite significant letter as the service heads into what's shaping up to be a particularly difficult winter, and one in the shadow of a general election. Since our last podcast, the campaign has been officially started. PERDA has begun, but this letter went out on Tuesday and has some quite interesting developments on the not at all abstract problem of pensions for doctors specifically. Annabelle, what does the letter? I should specify the letter is from Pauline Philip, who's sort of the performance czar for the NHS provider sector, the person who kind of gives trusts their marching orders on what to do and how to do it, and sort of monitors their performance. But Annabelle, yeah, what does the letter say about pensions for doctors?
So I think the letter is incredibly clear about the seriousness of the doctors' pensions crisis. It describes it as the most significant shared challenge relating to workforce availability. It does say nursing is a big part of this, but it also says the continuing impact of pensions taxes on doctors. And this has been a long-running problem. HSJ reported almost exactly a year ago that over the last 3 years, 250,000 NHS staff have opted out of the pension scheme over the last 3 years. So it shouldn't be a surprise, as this has been brewing for a while. The BMA have been incredibly vocal, as have the HCSA, about the impact on clinicians and therefore the impact on trusts, service delivery and patients, and of course patient safety. And just to perhaps dial it back a bit, as this is a really complicated issue. So we know that this has been a problem for a while. And in August, the government announced that it was going to act to introduce pensions changes to enable senior clinicians to take on extra clinical activities without incurring the huge pensions tax bills. And this was to do with tapering of the annual allowance. And I won't go into that, as I'm not a pensions accountant, but essentially once you hit a particular threshold income, the amount of annual allowance you're allowed tapers right down from 40,000. So the government said in August, quite interestingly, that it is going to look at the taper, which is quite a U-turn, as when the first consultation was launched in June, they didn't really mention the taper. So this letter talks about some of the flexibilities that they're expecting trusts to use to mitigate the impact of the pensions crisis on service delivery. Just to briefly touch on some of those flexibilities, employers have a number of options. So they can offer clinicians time off in lieu instead of pay. But then again, what is going to be the impact on service delivery of giving doctors days off in the most pressurised bit of the year? That's something to think about. There are a few other things that they can do. So you can split a full-time contract into part-time contracts. So this can help employees reduce the value of their pension benefits that they build up. There's also opting out and opting back in again. This is referred to as the hokey cokey, much less fun. And employers can also basically determine what sort of pay is pensionable. This depends on the nature and duration of the payment. Another thing that some trusts are doing, we published a story quite recently about a trust in Northumbria, is creating a limited liability partnership specifically for the completion of extra activities.
Right. Oh, that was what that was for, because Northumbria are often doing, let's call it, innovative stuff.
Well, they're not the only ones. I think quite a few trusts have had to resort to this because of the doctors simply saying we're not gonna take on any extra programmed activities because they're so concerned about the huge tax bills they'll be faced with.
And now Pauline Philip has pretty much mandated trusts take steps like this to do this.
Sorry, no, just to add on the LLP thing, that isn't something that's really endorsed by the DH or NHS England. That's not their preferred option, as their preferred fix for this, so to speak.
It's interesting, and presumably that's because Pauline Philip, who has a sort of operations room monitoring the pressures on trusts up and down the country, has said, look, we need to take this action now. I mean, can you give us an idea of, I'm sure people, if we have listeners in trusts, you'll be familiar with the sort of effects that the pensions crisis has had on the medical workforce, but can you take us through some of the actual practical effects that's had?
Absolutely. So we saw reported just this week that St Guy's and Thomas's hospital in central London closed an intensive care ward for, I think it was about 18 weeks. We're seeing, we're hearing trust reporting there's been a huge dent on waiting lists, as the consultants simply aren't there to see the patients. I think there are also concerns about, particularly in A&E, and we've had the president of the Royal College of Emergency Medicine just a few weeks ago warning that there are severe rota gaps at senior level due to the pensions crisis, and that obviously affects emergency medicine consultants as well. And in the winter, we certainly don't want to be short of emergency medicine consultants.
No, this is coming up for the most pressured time when you need senior staff to actually to reduce the number of admissions. The more senior staff you have, the more confident they tend to be in not admitting people when beds are particularly short. I mean, that does bring us to beds, because Pauline Philip also mentioned that we need to opening more beds. The acute sector in England needs to be opening more beds. I mean, yeah. James is our performance correspondent. How new is this?
So Simon Stevens said last month that he wanted the system to open more beds this winter. That followed a comment again by Mr. Stevens in June that the system would need more beds over the next 5 years than it has at present. That's a huge change in tact from the last decade or so, where we've seen the NHS trying to cut its bed base. Every winter, though, trusts try and open as many beds as they can, so-called escalation beds and extra wards. So it's a slight change in approach from previous winters, but certainly during winter you're trying to maximise the amount of capacity you've got. The Royal College of Emergency Medicine estimates this winter that the system is between 4,000 and 6,000 beds short. That's on an overall bed base of, in terms of hospital beds, at least of around 103,000. So yeah, there's considerable shortages, and this idea that the system should be opening more beds is going to be contentious, because trusts will already be thinking, well, we've opened all the capacity we've got. If you've got the physical capacity, you also need the staffing capacity as well. So it will not be easy for trusts to find either the physical capacity or the staffing capacity to open up more beds.
So basically, in each trust in the land, that difference between beds we need and beds we have is potentially someone being treated in a corridor on a trolley, kind of like we've seen quite a large growth in trolley weights on those statistics.
Indeed. So I think one of RCHEM's, the Royal College of Emergency Medicine's big push is around overcrowding in A&Es and trolley weights specifically. And we've seen, the numbers of trolley weights rocket. And this is because there just quite simply aren't enough beds in the system.
I wonder if kind of the advent of all-year winter, normally A&E performance recovers in the summer and people feel like they've got a bit of breathing space, but that hasn't happened over, is it just the past year or the past couple of years?
So we've been heading in a downward direction for the last few years. I mean, you could use July 2015 as a good date, because that's when the 4-hour target was last hit, the 4-hour accident and emergency target. So trusts heading into this winter are doing so off the back of the worst summer performance against 4-hour target ever. That's since records began in 2004. So just 85.4% of patients were seen within 4 hours in September. That's the last month on record. This is already worse than previous winter months, and nearly 4 percentage points down on the same time in 2018, last year. We're expecting the next set of performance data to come out on Thursday, so next Thursday, and again we're expecting the performance to have dropped even further. So why is all that happening? Well, one of the major reasons is the sharp increase in demand. There were 529,903 emergency admissions in September. That's 3.8% higher than the same month last year, and emergency admissions growth over the last 3 months is 3.6% and 4.9% over the last 12 months. So, rising demand, not enough capacity. The only outcome to that is that performance is going to dip, and we heard about the issue of the pensions crisis, and that's just exacerbated what was already a very fragile system.
And it sounds like it's important to point out that kind of the urgent care system is treating more people within the time limit than previously, but the demand is such that it's the performance overall is kind of so the proportion of people being treated within that time is falling.
Precisely.
And why is that? Lack of staff.
Precisely.
Lack of staff, lack of beds, lack of integration.
The fact that they are treating more patients within 4 hours is a great reflection on the work being done across the NHS. But it's a supply-demand deficit.
Yeah, and Annabelle, I believe from your local patch, we've got. Is this the first critical incident in these terms that we've seen this winter?
Yeah, I believe so. So that's Nottingham University Hospitals Trust. Yesterday morning declared a critical incident, and that isn't to say they're the only trust in the country under pressure. I've seen numerous trusts declaring black alert, now known as workfore. As I'm sure listeners know, the highest alert going up from 1 to 4. A critical incident is taking it further. It's kind of getting in system partners to try and ease the pressure. We were sort of seeing reports on social media that the trust had an extremely high number of people, I think close to 200 people in the ED, with numerous ambulances arriving in a space of 15 minutes. And this is just the start of November. Although I think with this trust, they were also experiencing very high pressure in July. They were declaring black alerts in July, which is quite unusual for an area of the country that isn't a big tourist destination. So we might expect that from Cornwall, and indeed we did see that in Cornwall, but not so much in Nottingham.
Yeah, no, that's interesting, and it's important to like Nottingham University Hospitals Trust. This is not a small DGH. This is kind of a giant workhorse trust for a whole region. Anyway, kind of the performance of the acute sector, how we measure it, is something that's also come up in news terms quite recently, because we're changing all these terms, aren't we, James? Kind of like there's a big review of it going on.
Yeah. So the clinical standards review, which is the review of all the NHS's core constitutional statutory targets, it was actually kicked off by Theresa May when she was Prime Minister, which just feels like a different age. But there you have it.
This is 4 months ago.
Indeed, indeed. The review published its latest kind of progress report last week. And the main thing we're going to focus on today is the 4-hour target, because that's the NHS's most important performance.
Although the review is
metrics.
Also going to look at like
the review's
elective
looking
and cancer waiting times,
exactly.
But A&E has soaked up a lot of the attention because, like you say, it is the main bellwether of how well a system is functioning.
And it also things like bed occupancy targets are predicated on the 4-hour target being hit. So a lot kind of flows from it. And the 4-hour target, I mean, it's important just to kind of step back a minute and say, well, what has the 4-hour target achieved? Well, it's achieved a hell of a lot since its introduction in 2004, kind of played a huge role in cutting waiting times during the noughties and the early part of this decade, from the dark days in the 90s, where kind of waits were sometimes measured in days rather than hours. So we all have a lot to be thankful for the creation of the 4-hour target. So why do system leaders want to replace it if it's so great? Well, like any target, it's not perfect, far from it. Among sort of the issues raised about it is it drives some perverse behaviours, with perhaps the most pronounced being the huge spike in patients you see dealt with at kind of 3 hours 55 minutes, just sort of before the 4-hour deadline, which suggests some patients being dealt with because of the target rather than clinical need. Now, there's also the issue, as previously mentioned, that it hasn't been hit since July 2015, and it's kind of hard to get away from the fact that this appears to be a major incentive, a major reason why system leaders and politicians would like to see it gone, because it sort of causes great embarrassment every month when it comes out. It's another month, they haven't hit the target, things are getting worse, etc. Doesn't look good. Of course, no one would say that. The official line is this is all about clinical outcomes and delivering better services for patients, but that's certainly the elephant in the room for NHS England. So should it be scrapped? Should it be scrapped depends entirely on what it is replaced with. So if the review group can demonstrate that they've got this metric which delivers better clinical outcomes, and they can demonstrate that robustly, then yeah, perhaps the day has come where the 4-hour target will say, thank you for your service, goodbye. But this is a huge challenge. There's been quite a lot of work done previously on replacing it, and this has failed. So this does feel different to previous efforts to replace the 4-hour target, in that there's kind of more political and clinical enthusiasm for reform this time around. But as I say, the review group has to demonstrate that it really has something that's better for patients.
And they're testing it at 12 or 14 different trusts.
14 pilot sites.
14 pilot sites.
Yeah.
And what they're proposing what they're testing is a mean patient time. So you take everyone who attends, and you. I remember reading one potential problem with that would be it could sort of disguise some extremely long waits. If you kind of go, if the overall performance is, if you're whipping through a lot of patients quite quickly, the 8 people who've waited what you might consider an unacceptably long amount of time are sort of hidden in a mean performance.
The average mean time is the main metric that they're trying, but they're also trying these shorter targets for the most critically ill patients, and a couple of others. So it wouldn't just be mean, but mean would be the sort of cornerstone of any new system. So they've tested this, and they've actually found that patients were waiting longer overall. And you think, oh well, that's a bad thing. But the latest report suggested that actually there's been less admissions, and the admitted patients were waiting slightly less. So their weights had fallen by about 3 minutes to 5 hours and 12 minutes following the removal of the kind of 4-hour cliff edge. So the review would suggest that this is a positive development, but the overall verdict from independent experts and indeed review leaders themselves is it's too early to make a judgment. John Appleby, who's the chief economist at the Nuffield Trust, told me that the central problem is that if you have some people being better off and some people who are being worse off under a new system, and that's what the data suggests so far, how do you reach a decision about whether it's a good idea to change the system? And they've never really set out what the criteria is for this. Now, this may be that they haven't really worked it out yet, and that is happening as part of the process. But I think the kind of lack of transparency around this process, the lack of transparency around the criteria, really is pretty concerning. There's also, it's a review that's been carried out at breakneck speed. Frankly, they want to be rolling out new metrics from April. But they only want to make final recommendations in March, which doesn't seem to give any time for any meaningful consultation. Now, NHS England has pledged to consult. It said that it will do this in early 2020, so in sort of January, February time, before final recommendations in March. Well, that kind of looks like putting the cart before the horse, really, because how can you know what to say if you don't know what the final recommendations are? So there's some concerns about the transparency, speed at which it's going, and the potential gap in meaningful consultation.
Yeah, it's sort of slightly concerning that the idea that the clinicians in an emergency department would ever sort of prioritize one patient's care over another, over a more deserving case, just to come in under some target, to come in at like 3 minutes 58, rather than if someone genuinely had higher need, then you would hope and expect that they would always see the person high need. I mean, that's what triage is. That's what they do. So, I mean, the 4-hour target, I've had hospital chief execs say it's a very neat way of showing where the pressure is, of showing the health of the whole urgent care system, from the discharge out to care homes or home, through the effectiveness of the flow through the hospital, to the effectiveness of the system's kind of preparations for avoiding unnecessary attendances. So anyway, it'll be interesting to see where that one ends up. But certainly the fundamentals of it around kind of the inputs and outputs, like what we have in terms of workforce, everyone agrees it's roughly 100,000 vacancies.
Yes, that's
nationally, right. and 40,000 nurse vacancies.
Yeah, about 42,000 nurse vacancies. Although it's actually very difficult to accurately measure how many vacancies there are in the NHS, as it's something that is counted by job adverts posted on the NHS jobs website.
That's how they work out.
Yeah.
I just figure, like, given the sort of the centrality of that as a factor, kind of should we be expecting, have we seen much in the way of, I mean, we're in the middle of a general election, we're at the beginning of a general election campaign. Have we seen, or should we expect to see much in the way of kind of workforce policy being put front and centre in people's NHS offer?
Well, as of yet, I haven't seen an awful lot about the workforce, which is perhaps disappointing, particularly considering some of the contents in this letter, actually, and the real concerns there are about a workforce deficit and the impact that will have on performance. So I think so far we've seen some quite kind of big announceables from the Conservative Party, and such as new equipment, scanners. Boris Johnson's been doing an awful lot of hospital visits. But in terms of what Labour's putting out, I think there's been a focus on the NHS is not up for sale. That was something that Corbyn really honed in on his very first election speech. There wasn't any mention of workforce. And although earlier this week, Labour did put out some FOIs they'd done on the number of operations that have been cancelled, and of course staff shortages and poor equipment, I think, were the main reasons for this. So actually, I think I was quite interested to see how this sort of messaging has been cutting through to the public. And it is, it's important to say it's early days in the election campaign. The manifestos haven't been published yet. So, I think perhaps we could expect something on pensions perhaps in the Tory manifesto. It's not necessarily going to be a big vote winner for the general public, as from their perspective, doctors are very high earners, so how's that going to benefit the public? But then I suppose if you make the point that actually without these doctors, they're going to receive potentially poor care in the NHS. So there's quite a strong relationship there. I think people can understand that, having to wait longer in A&E because there's no consultant to see you and discharge you. So I spoke to Ben Page, who is chief executive of pollsters Ipsos Mori, and he made the point that the public always say the biggest problem in the NHS is that there's not enough money. And in terms of the privatisation line, that seems to be quite a strong line that Labour have taken at the moment. He said that people are more interested in resources, and Labour need to show the relationship between privatisation and less resources in the NHS. He said that people are not as ideological about privatisation as Labour. They don't always like it, but they accept that sometimes it's necessary. So another interesting point raised in that conversation, actually kind of relating to the international workforce and immigration, was the idea of an NHS visa.
Because, sorry, that is one of the big ways you can very quickly address a workforce shortage. So NHS Trust have been going around the world, like recruiting heavily from India, the Philippines.
India and the
Spain
Philippines
and
are the two biggest countries. I think we have over half our international staff, I think, are from India and the Philippines. They're a big group, especially doctors, often from India, nurses from Philippines. There's some of the trends that you can see. So the two parties, Labour and the Tories, are obviously polarised on this issue. Labour has a conference commitment to keep free movement, so to speak, and the Tories are, we heard Priti Patel speaking at the Tory conference saying it's going to end once and for all. And we've seen over months, NHS experts and leaders have been warning that would be absolutely detrimental to the health service, the health and care service, obviously. Social care workers, absolutely, yeah. If it's made more difficult for them to come and work in the NHS, our shortages could get even worse. And as you very rightly just said, that the only way in the short term to ease workforce pressures in many trusts is international recruitment, as it takes over 5 years to grow a doctor and 3 years for a nursing degree, and further postgraduate education to become more specialists, or indeed to work in the community, because community nursing, district nursing is a real problem area. Over the last 9 years, I think we've seen a 42% decrease in district nursing, which is huge and can really block.
That's roughly half that workforce that used to be out there doing that work is just not there anymore.
Absolutely, and I think they play a vital role in, we were talking about flow earlier, and getting people out of hospital to home, and often the blockage in that care package sometimes, that plays a big part.
So this is maybe why we're having to open more expensive hospital beds to deal with people who maybe don't need to be in hospital, because time and again the NHS hasn't put community facilities in place. I wonder how we came to lose 42% of district nurses. That's quite scary. The parties have different lines, like you say, on the freedom of movement, but isn't that just an EU issue, or do they mean more generally on that?
So the situation as it stands is EU workers can apply for, and many have settled or pre-settled status, so they're secure in their jobs in the UK. I think the question remains what will happen in the future. So there's some consultations going on at the moment, the MAC, on a refined points visa system.
So that's the what's the MAC?
So sorry, that's Migration Advisory Committee.
Right, that's which sets policy for.
Yeah, so the government's asked them to consult on what a future immigration system could look like, and there are concerns that if a salary threshold is set too high, to be a skilled worker allowed to come and work in this country, could have disastrous impact on workers who are not on the shortage occupation list, and for social care workers as well. So I think so I was talking to Ben Page about this idea of an NHS visa would kind of sounds like it would be a bit similar to the shortage occupation list, but it would just, the shortage occupation list can change. It doesn't say the same. Nurses aren't necessarily, although I can't imagine them not being on it, but that it's not set in stone that they're always going to be on it. So apparently about 6 in 10 people are supporting an NHS visa, which I think that says quite a lot about he said the pragmatism of the public when it comes to the NHS. I wonder whether politicians will also recognise this.
Yeah, that would be an interesting departure. People go, okay, we're prepared to put behind other bits of our immigration policy because this is a priority, and because I think it's important to stress, like the pressures on the system that we see couldn't be more related to the 100,000 vacancies that we have. So if you're proposing to make that worse in any way, then that's a difficult sell. Thanks, James. Thanks, Annabelle, for taking us through that. We're back next week with the next weekly Health Check podcast. You can download that from all of the normal places you get your podcasts from, and also from the hsj.co.uk website. If you've got any things you'd like us to discuss, please send them in. My email is ben.clover@wilmingtonhealthcare.com. We'll see you next week. Thanks very much.
Thank you very much.
Thank you.